Hi, everyone. Good morning, good afternoon, and good evening to everyone who is participating to this webinar today. Thank you so much for participating and being with us today. So today we will speak about addressing inequalities through the MPDSR system, the Maternal and Perinatal Death Surveillance and Response System, and lessons learned from Sierra Leone. I'm Francesca Palestra, and I'm a technical officer in the Maternal Health team at the Department of Maternal, Newborn, Child and Adolescent Health and Ageing in WHO Geneva. And today is the International Women's Day. So I would like to congratulate all the women here today and also remind everyone that really the cost for a society of losing women and newborns of preventable deaths is incredibly high for their family, for the welfare of a society, and for many, many other reasons. So thank you so much for being with us today. Next slide. So today, after the introduction, we will have a presentation from Dr. Francis Moses, Program Manager, Reproductive Health and Family Planning Program. Then we will have the panel discussion made of Matron Morgan Mana and Dr. James Queerer that I will introduce later from the Ministry of Health in Sierra Leone. And then we will conclude with questions and answers and closing remarks. Next slide. So we will have a question and answers at the end, as mentioned before. So please, we invite all of you to post your question in the chat box. Usually, this is a question that comes up. There is no translation available during this webinar. It will be in English. And the recording of this webinar and also the slides will be shared with all of you. So I would like now to introduce Dr. Francis Moses. Dr. Francis Moses works for the Ministry of Health in Sierra Leone. He is specialized in sexual and reproductive health with a strong background in developing, implementing, and evaluating public health programs. Dr. Moses has worked in public and private sectors in Sierra Leone, both as a clinician providing SRH, obstetrics and gynecology services, and as a public health expert at central district level, successfully leading a district health management team and managing disease outbreaks, including the Ebola virus disease. Currently, Dr. Moses is a program manager of the National Reproductive Health and Family Planning Program of the Ministry of Health and Sanitation. So he has been in this position for 4 years, working with local and international partners and donors. So we would like now to welcome Dr. Moses and his presentation on addressing preventable maternal and perinatal deaths during pregnancy and childbirth by implementing the MPDSR system in Sierra Leone. Thank you so much, Dr. Moses, and over to you.
Thank you very much, Francesca. I'll quickly share my screen. So, hello, everyone. I'll quickly talk us through our MPDSR system in Sierra Leone, and this will be the outline of the presentation. So,
Moses, sorry to interrupt you. Can you please put in the display mode, like a bigger, go in the display settings up there. You can go in the slide mode, I think. Yes. Yes, exactly. This
is it better? Okay, great.
No, it's the same. Sorry. Did you click on Swap Presenter View and Slideshow?
Yes, that's what I did.
Okay. So, okay, but we can go on in the meantime. Sorry to interrupt you. I hope everyone can see the slides. Yeah, maybe just try to re-share your screen again.
Yes, I'm trying to do that.
Thank you. So we have already 88 participants today. So thank you very much, everyone, for joining us. It's really a pleasure to have you all. And Dr. Moses has many good experiences and lessons learned to share with us on the Sierra Leone experience.
Is it better now?
Yes, I think it's loading.
Are you seeing? Okay.
Yes, perfect. Now we see you perfectly. Thank you so much.
Great. Is it okay? Fine.
Yes,
Okay,
perfect.
great. So
Thank you so much.
now, these are just a few key health and demographic statistics for Sierra Leone. We've got a population of about 7.5 million people and about 51 hospitals and a little under 1,300 primary healthcare facilities to serve the population. We've got a low health worker to population ratio of 0.34 per thousand population. And we have over 250,000 deliveries annually, with about a little over 250,000 live births, which includes multiple pregnancies. For the maternal and child health statistics, our ANC coverage is very high. ANC 1 is almost 98%. ANC 4 is about 76% based on our DHS survey in 2019. We've got a high institutional birth rate, so 83% of women give birth in a hospital and are attended to by, and 87% attended to by a skilled birth attendant. MCPR is also relatively high. However, we have relatively poor impact indicators, high maternal mortality rate at 717 per 100,000 live births. Also relatively high stillbirth rate, neonatal mortality rate, and our life expectancy at birth is 54.3 years. Gender-related statistics, we have low numbers of women, low proportions of women participating in key decisions in the home. Only about 43% of women actively participate in key decision making. But when it comes to family planning, the wife makes the decision almost half the time for family planning. For gender-related statistics, our gender-based violence rates are relatively high, with 61% of women aged 15 to 49 having experienced some form of gender-based or sexual violence. Female genital cutting is also relatively high. 83% of our women aged 15 to 49 are circumcised. So in summary, we've got poor gender and women's empowerment indicators. We've got inadequate skilled human resources for health. We've got relatively good process indicators for RMNCAH, but then our outcome indicators remain relatively poor. Our RMNCAH investment case has three main goals. to achieve gender equity and equality, to eliminate all forms of GBV and discrimination, and to strengthen our health systems for IMNCH. So as part of this, we introduced and institutionalized MPDSR in Sierra Leone. We developed our policies and our strategies to include MPDSR, and we've been doing maternal death surveillance and response since 2016. We started MPDSR in 13 hospitals sometime in 2018. So our MPDSR system has two main objectives: to report all maternal and perinatal mortality, and to review these reported cases of mortality and identify the major medical and non-medical causes, formulate appropriate interventions, and work out how we can improve on that. So this slide shows a timeline of our MDSR processes. We started recording and reporting maternal deaths ad hoc since 2014. And by July 2015, we had done our own national guidelines disseminated by November and trained our healthcare providers by January 2016. And we also set up our district and national MDSR committees around that time. We then developed standard operating procedures in 2017 and started publishing our annual MDSR report since then. So each year we publish our MDSR data for the previous year. We've got high-level political buy-in for this. The first report was launched by the president in June 2017. And to streamline our reporting, we introduced ICD-10 to our service providers around 2017. We then started working with the quality of care program, which was introduced to the ministry in 2017. And they also have been very integral part of our MDSR and MPDSR processes. So this slide shows our surveillance system for MPDSR. We've integrated MPDSR into our integrated disease surveillance and response system, which came about as a result of our response to the Ebola outbreak. The IDSR system collects data on notifiable diseases, including maternal deaths and perinatal deaths, and that is reported on a weekly basis. We've also got an MDSR reporting system on the side, which reports monthly after suspected maternal deaths have been investigated by our district level case investigation. So the MDSR data reporting is done electronically with tablets. You can see here one of our health workers doing the data entry. And this makes our reporting easier and faster, and we get data on MDSR on a weekly basis. So we've got really relatively high reporting rates. So we exceed the AFRO target of 80%. This is a snapshot of the reporting rate for week 8 of this year. And you can see that we're even exceeding our national target with almost 100% completeness and timeliness of reporting in all districts. So every year we collect the total number of maternal deaths in the country. And since 2016, we've recorded on average 500 to 600 maternal deaths each year. However, our maternal mortality rate is at 717 deaths per 100,000 live births from our 2019 demographic health survey. In 2020, we conducted a mortality surveillance study, which showed that our maternal mortality estimate was at 510 deaths per 100,000 live births. So which means that at least we are having 1,480 maternal deaths every year, but then our MDSR system is picking up about 546 deaths. So there is that discrepancy. So when you look at when you compare the reported maternal deaths picked up by MDSR to the maternal mortality ratio calculated from the surveys, the mortality surveys that have been done, you find that there is a reporting gap of about 60%. So about 60% of the estimated deaths, maternal deaths, are not reported. This graph just shows the maternal deaths by district. We found that maternal deaths happen mainly in our hospitals, our health facilities, with fewer deaths happening in the community and even less so in transit. For perinatal deaths, we started, as I said before, in 2018 to report perinatal deaths. These are done in 13 health facilities in special care baby units. And you could see that antepartum stillbirths are by far the commoner the commoner forms of stillbirths that we see in these health facilities. For neonatal deaths, we also can see that early neonatal deaths within the first 7 days of life are more common than late neonatal deaths. So we're only getting 40% of maternal deaths reported through MDSR based on the estimates of our surveys, and we've been trying to figure out how we can address this issue. And so we've instituted a number of activities that we hope would help us fix the problem. Now, who collects the data and conducts the reviews? We've got district investigation teams that consist of a disease surveillance officer, an MDSR coordinator, and a midwife investigator. And we've got 3 levels of MDSR committees: at hospital level, at district level, and at national level. These photos show the processes of reviewing and investigating maternal deaths. So every maternal death finds its way into a line list, which is online in DHIS2, and we can be able to analyze the line lists. We analyze and report our maternal death data every year. We print a report. So these are the published reports since 2016. We found that many of the women, 65% of our maternal deaths are among women aged 20 to 34. And more women are dying during the 2nd to 4th pregnancies. And 71% of the women who died had gone to antenatal care for at least 3 to 4 times. We also found that 2/3 of maternal deaths occurred after delivery. And women spent, at least half of the mothers who died spent at least 24 hours in hospital. And almost 3/4 of them spent 7 hours in hospital. So the question is that are hospitals ill-equipped to save the lives of our women? And so we need to focus on our hospitals. Now, these are the causes of maternal death analyzed from 2016 to 2020. And the 3 commonest causes of maternal death are hemorrhage, hypertension, and sepsis, which account for about 76% of all of the maternal deaths. Contributing factors we've also looked into, and we've modeled them according to 3 delays. So at community level, making that decision to come to hospital, we find that many of the pregnant women are not aware of the danger signs of pregnancy. And then moving the pregnant women from lower level facilities to hospitals where they can get care, that's huge delay as well. Referrals from lower level to higher level facilities. And then at the level of the hospitals themselves, we found that there is poor adherence to our emergency obstetric and neonatal care guidelines, as well as delays in providing care to these women. So these are the areas that we're focusing on to improve on the services we provide for women. So what are we doing? We already know the stories. Our response and best practices that we've instituted since we started MPDSR is to focus on health system strengthening. So building human resource capacity, training of healthcare providers like midwives, and then quality of care improvements as well to improve on the services being provided at the point of care. What are the challenges that we faced? Blame culture in the hospitals. You know, we keep this is one of the most difficult of the challenges we experience. Punitive measures against service providers who are deemed to have made a mistake in providing the services. Data discrepancy, quality of the investigation and the reviews. And then at community level, most importantly, we need to build the capacity of our community-based surveillance because it's still not as strong as we hope it should be. So what we're currently working on at the moment is to create friendly policy and legal environment for MPDSR. We're strengthening our quality of care approaches. We're strengthening the quality of the MPDSR investigation teams and committees. And we're strengthening leadership and coordination for MPDSR and quality of care. So that's where I'll end. I hope that I've been able to provide you with an insight of what our MPDSR system looks like in this area.
Thank you so much. Thank you so much, Dr. Moses, for the incredibly comprehensive presentation. It's really fantastic to see how many things and how did you go in a depth analysis in analyzing really the preventable causes and all the work that really is going on in Sierra Leone on this at many levels. So thank you so much. We have already many questions from the audience that I will ask you during the Q&A. Thank you very much. So now we will continue sharing the screen and we will move to the panel discussion. I will introduce you our speakers. So we have, here we are. So we have Matron Margaret Manna, who is a program manager of National Quality Management Program. So Margaret is a midwife specialist with over 30 years of midwifery experience at clinical, academic, and public health institutions. Margaret is currently the program manager for the National Quality Management Program, the directorate at the Ministry of Health and Sanitation. She's also an associate lecturer at the College of Medicine and Allied Health Science in Sierra Leone. And prior to that, she served as a country midwife advisor and national SRH program specialist for UNFPA country office in Sierra Leone. So welcome, Matron Margaret Manna. Then we have Dr. James Square, who is a program manager at the National Disease Surveillance Program. Dr. James is a medical doctor and public health professional with more than 12 years of experience working at strategic planning and implementation of disease control program, administration, disease surveillance, public health emergency response, and human resources capacity development and research. So Dr. Square is currently the program manager for the Sierra Leone National Disease Surveillance Program at the Ministry of Health and Sanitation, which he has held since June 2018. In his current position, he has successfully implemented the electronic-based integrated disease surveillance and response at all levels of the health system, including the public health facilities across the country, positioning Sierra Leone as the first country in the sub-region to implement electronic disease surveillance at lower health facilities. So we would like to welcome our speakers. if you can also show your video, if possible, when you speak, and mute yourself when you are not speaking. So I will start. With the first question for Matron Margaret Mana. So from the presentation, we have heard that about the new quality management program in Sierra Leone, and there was also a question in the chat box about this. So how it has improved this quality management program, the MPDSR process. And can you please share some key factors that led to the successes, especially in the response aspect of MPDSR? Thank you so much.
Good afternoon, everyone. Greetings from Sierra Leone. Thank you very much, Francesca, for the introduction and also the questions that were asked. Yes, indeed, I have listened to the wonderful presentation of Dr. Moses. Of course, we have been in this journey for like over 2 or 3 decades now. So I would actually want to say that the MPDSR process laid the foundation for the establishment of the quality management program, because individual stories about maternal deaths, we have seen it, we have had it, and that actually made us to come to the point that poor quality of care was a very major contributing factor to maternal and also newborn deaths in facilities as well as communities. As you can see, poor quality of care is divided into 2. There is service delivery and also the client experience of care. Sierra Leone is a country wherein, according to the presentation, you've seen that at least women take over some hours in facilities before their final demise. So that shows that facility readiness it's key. The facilities need to be ready. And additionally, the processes also enable us to learn the stories for each cause of every single maternal death. So this is not like formerly we used to see the numbers, but behind the numbers, we didn't know. But Sierra Leone currently, we know now why they are dying at these facilities and why everybody is moving from community. Because I see a question somebody was asking, why is maternal death more increased? Well, that is one of the good benefits of MPDSR. Now, they used to die in communities, but now they are pushing them to the facilities, and we have no way of sending them back. Additionally, what I would like to say also, it has helped us to develop change packages in at least knowing the major causes of maternal deaths. That has led for us to develop change packages so that introducing it and utilizing them, because we have seen inadherence to lay down guidelines and protocols. So these change packages are going to be like mandatory for every facility within this country. Thirdly, it has helped us to establish learning facilities, because initially investments have been made, but we have been like scattering our efforts. Now we are trying to bring the efforts to major sites where we think that's where the women are dying mainly. So I think with MPDSR, it has really helped us in streamlining in terms of quality of care, where we need to put our effort and invest our resources. Thank you very much.
Thank you very much. This is a very comprehensive answer. Indeed, it's really quality of care is a contributing factor to the death of or well-being, based on how we want to see it and how is really the quality of care of services that we provide to women and newborns. Thank you so much. Now I would like to pass to Dr. James Squire. So we know that Sierra Leone has made significant progress in instituting integrated disease surveillance and response, and has now moved to 100% electronic reporting. And you were a pioneer on this. So how does the existing IDSR system add value to the MPDSR process? Thank you so much.
Yeah, thank you very much, Francisca. And let me also join Matron Mana to thank Moses for the beautiful presentation. And let me join all the caring men to wish all our women a happy Women's Day, and also extend my condolences to families who have lost their loved ones due to childbirth. Maternal death was one of the high priority for the government, and it was declared a national emergency. So as a program, we reviewed our IDSR guideline, that is during 2015, and we ensured that we captured maternal and perinatal death as a notifiable event that requires immediate reporting, and it is mandatory for all our surveillance sites to report on maternal death and investigate those deaths. And also what we did on a weekly basis as well, we summarize those reports, and we have a forum because the National Disease Surveillance Program is under the Directorate of Health Security and Emergencies. And on a weekly basis, on Wednesdays, we have an EP that will present data from all our reporting sites. And maternal death is one of the conditions or event that we actually discussed in that meeting. And during that discussions, the action point that comes out of that discussion point, we forward to Dr. Moses' office for decisions and actions to be taken. And also we try to strengthen our community-based surveillance because surveillance starts at the community level. So we trained community health workers, and we train them on 10 priority conditions event, and maternal death is one of them that we actually train them to be reporting to the next level of the health facilities once a woman dies within the stipulated period. And also we often conduct periodic data quality audits in all our reporting sites to strengthen data quality issues that are related to maternal death. And we also aid our reporting sites with IDSR reporting tools, at least to facilitate reporting and investigation of all maternal death and cause. And we also created a case-based form, because for every maternal death and cause, it is being investigated by a joint team, and we are operating on the DHIS2 platform. So we created that case-based form, which is easy for data visualization and for actions to be taken by the program. And we have also adapted standard guidelines and patient protection policies to improve on maternal death reporting in all this. And periodically, we also conduct mentorship and supportive supervisions to all our reporting sites. So basically, we support the national program, Moses' office, in ensuring that all our reporting sites actually captures and reports maternal deaths, and those data that are reported are being investigated and then are reviewed at the district level, and also even us at national level. Also, we have a weekly meeting that we hold, and we present those reports to Dr. Moses' office. Yeah. Thank you.
Thank you very much, Dr. Square, for this answer. It's very fascinating to see how you really linked all of this program with the community-based surveillance, on how you are really training to reporting, and also especially the periodic data quality audits in case there is something missing. So thank you very much for all this good work. I will continue with then asking a question to Matron Margaret Manna. So the next question is, what systems have been put in place to monitor the impact of quality of care interventions for improving maternal survival? Over to you. Thank you very much.
Thank you very much, Francesca. In responding to your question, the quality management program, we have created leadership and governance structures at all levels to facilitate coordination and reporting of quality of care interventions. We have now dedicated salaried QOC officers and coaches at district and hospital level. They are spearheading quality of care at sub-national levels. Then we have instituted QI teams in all maternity points of care, and the QI projects are documented, and we are encouraging them to report on a regular basis. We have created WhatsApp forum where on a day-to-day basis, on a weekly basis, we see how the QI projects are faring on, and if there are issues, we rectify it immediately. Additionally, we developed and rolled out the QOC dashboard, the RMNCH scorecard in the DHIS too. So today, as long as DHIS is operational, you'll see the RMNCH scorecard as well as the QOC dashboard that is tracking on quality of care indicators. The community scorecard, since community empowerment and education is key for client satisfaction, is underway for developing. Very shortly, with the support of my partners again, the Ministry of Health, we will implement that as well so that we'll be getting independent feedback from communities. We have also conducted periodic learning sessions at a facility, district, and even national. Last year, we held our first national conference on quality of care, where a lot of information we have obtained from our QI project was disseminated, and our partners witnessed it. We are also doing regular monitoring and analysis of the global and national QED common core indicators. Then we are working on periodic publication and reporting on the progress and successes of quality of care around the country. So these are a few steps that we've put in place to actually ensure that QOC interventions are monitored for the improvement in maternal and child survival in Sierra Leone. Hello, Frances.
Thank you very much, Matron Mana. It's really fascinating to see really the leadership commitment on this, and as also the use of the quality of care dashboard and the analysis of common core indicators to link the two programs. So now I would pass to the last question before the Q&A for Dr. Squirrel. So Dr. Squirrel, we also see that the notification rate for maternal death in Sierra Leone is estimated at 40%, with a significant number of maternal deaths being underreported. So how does the surveillance system aim to address these challenges? Over to you. Thank you very much.
Yes, thank you very much, Francisca. So one of the things that we actually are doing is working with the reproductive health and family planning program to ensure that we develop suitable policies and legal environment that is non-punitive for our health workers. Because once our health workers think that, if they report maternal death, punitive actions will be taken, they will not report. So we want to create that environment for them where it is non-punitive and encourage them to report. And also we are continuing to strengthen our community-based surveillance system and ensure that all maternal deaths are being captured at community levels. And most importantly, we established the National Civil Registration System in 2018. We are working with them collaboratively to see how we can strengthen that system to ensure that strengthen vital statistics registration and monitoring and reporting system. And we also intensify screening of every single death of women for suspected maternal death. In fact, we actually in the process of winning a grant from the Bill and Melinda Gates. We are now in the final stage of approval. And one of the activities, the grant is actually to strengthen surveillance systems. And one of the activities that we included is see how we we establish a real-time mortality surveillance system that actually captures deaths that occurs any part of the country on real-time basis, and see how we integrate that into the civil registration system. So those are all some of the things that we actually put in place to ensure that all deaths, including maternal deaths, is being counted. And for those that are of maternal death, we investigate those deaths and see actions that can be taken from the reproductive health program. Yeah, thank you.
Thank you very much, Dr. Squarer. So now we will pass to the Q&A. I will ask a few questions to the speakers that have joined us today. So let me go over Dr. Moses at first. So we have a question from the audience related, like, does the MPDSR system include a community-based surveillance system? I mean, I know that during some presentations have been already answered a bit, but if you can formulate a little bit better how at national level you are including the community-based surveillance in your program on MPDSR. Thank you so much.
Thank you very much, Francesca. Yes, we have included a community-based surveillance system as part of our MPDSR, and that is something that took hold since the Ebola outbreak. The major challenge we're having with the community-based surveillance system is our case definition for maternal death, which is the death of any woman of reproductive age. And so the data we're getting is so large that it becomes very challenging to investigate every reported suspected maternal death and then confirm. So at the moment, that is one of our challenges, developing the resources to fine-tune our investigation of maternal deaths at community level. We are
Dr. Moses, we lost you. Okay, so maybe I can move to a question to Matron Margaret. In the meantime, that Dr. Moses reconnects with us. So we have a question from the audience asking, with poor staffing, with poor medical and nursing staff, what motivates nursing staff to continue the quality improvement work in your experience?
Thank you very much, Francesca. Sorry, we have some hitches here. Can you hear me now?
Yes, we hear you well now.
Okay, thank you very much for that question. In terms of poor staffing, what motivates our nurses to carry on? One thing I have told you, MPDSR actually laid the foundation for quality of care, wherein when we go for MDSR investigations, we ensure that they are part of the team. They sit in and listen to the stories. Then we go through the chats together with them. So they see the issues that are coming up from the client's chats and the patient stories. That at least has created an innate motivation for them to see that this we have been doing, we have not been doing right, especially with poor documentation inadherence to lay down protocols and guidelines. So I think wanting to change or wanting to be part of the change that they want to see has actually kept them on their toes to be able to be part of the QI project. And also the learning sessions we have been conducting, you know, they have seen using the QI methodologies or approaches like the fishbone, the Pareto diagrams, they have seen that we have huge challenges and there are some that we can handle at our level. So using some of those methodologies, they've been able to really say, okay, this is something that we want to see change. And those experiences they have shared with other colleagues in other units has actually served as one of the other key motivating factors for them to be able to continue with their QI projects. Then when we had the National Learning Conference, you know, some of these stories, we made them into posters and it was presented. So for that, I think they were recognized and it served as motivation. So these are some of the few steps that we have done. And seeing me around, they see me as their role model because we have lived to see it. And some of them has actually been near misses. And that has given them the innate motivation as well for them to carry on. So basically, these are some of the things I think it's keeping them on. Over to you, Francesca.
Thank you very much, Matron Margaret, for your answer. So I would like to ask a question to Dr. Squire. So we have a question from the audience specifically on perinatal death, because the presentation has been focused on MPDSR in general, but there is the need of knowing if there is in-depth perinatal and newborn audits in Sierra Leone, and how these are conducted at facility level, if are action taken for newborn and perinatal death. And also additionally, if you have formal tools for newborn audits that you would like to share with them. Dr. Squire? I think we are having some connections.
So maybe I can cut in for Dr. Squire. Yes. This is Moses. For MPDSR, as I said before, we started sometime in September in 2018, and we've been focusing mainly on our hospitals with special care baby units. The reason is that our perinatal mortality rate is relatively high, and putting together the infrastructure to do this nationwide in all health facilities has been a bit of a challenge. But that's the plan. We'll be able to do this in all of the health facilities and integrate this into the maternal death surveillance and response system as well. And we would then be able to do a composite and harmonized mortality surveillance for both mothers and babies. Over.
Thank you very much, Dr. Moses. I have another question for you. So we have the audience asking, what actions are being taken to ensure referrals from lower level facilities to address delays in emergency care? Yes, this one.
Yeah, thank you. In 2018, given the high numbers of women that were dying because of that delay in reaching care, we started a nationwide ambulance service called the National Emergency Medical Service. So this service works on referrals for women from lower level health facilities to hospitals. And we've got a network of about 160 ambulances across the country that help move women who require referral from lower level facilities to hospitals. Unfortunately, this system also has its own challenges. It requires a lot of resources to maintain and keep running, and sometimes the system fails. And it is in these situations that we experience a lot of challenges with moving women from lower level to higher level facilities.
Thank you very much, Dr. Moses. I have another question for Matron Margaret Manna. So we see that does Sierra Leone have adequate commodities to manage PPH? And is there a PPH prevention services available? Over to you, Margaret.
I think it would be easier for me to answer that one as well. You know, we already have oxytocin for management of the third stage of labor, but you know, oxytocin needs a temperature controlled environment for storage, and our cold chain also has a lot of challenges in these remote areas. So at the moment, we're working on introducing heat-stable carbetocin in these hard-to-reach communities where we have problems with the cold chain. We've also tried to introduce tranexamic acid as one of our mainstay medicines for managing postpartum hemorrhage. But then at the moment, this is only limited to referral hospitals. And we're working on a scale-up of the introduction of tranexamic acid to all of our health facilities. The thing is, we run a free healthcare maternal and child health service here in Sierra Leone. And it's sometimes challenging getting all the resources to provide the requisite drugs and supplies that all of our health facilities need to be able to provide comprehensive free healthcare. And because of these challenges, we're sometimes unable to meet the needs of all of our population. And I think that is why last year we started working on a social health insurance scheme for pregnant women. We're calling it SLESHI, and not just for pregnant women, but for children under 5 and all other vulnerable groups as well. And we're hoping that this would help supplement or complement the free healthcare system, so that we would be able to provide all of the resources that our healthcare providers require to be able to save the lives of these women in our health facilities.
Thank you very much. It's fascinating how different modalities and allies are also inside the country is possible really to make in order to prevent maternal mortality from PPH. So and now I have another question concerning for you. So how do you can we understand? It was, sorry, what was 1 second, I lost it. It was highlighted. Okay, so we saw that there is a higher mortality in hospitals rather than communities. So can you please a bit explain this factor that you already explained during your presentation, Dr. Moses, but some audience raised the problem and asked why is this the reason?
Thank you very much, Francesca. One of the key issues we have in the country is underreporting. There are issues around underreporting, so it's very difficult for us to get information from community around that particular issue. Then additionally, you all know we said one of the challenges are punitive measures, you know. So it's like maybe scaring people. If these events are happening, like maternal death occurring in communities, it is very challenging for them to come up clearly to say at least somebody has died. And the other thing is with introduction of this MPDSR or the surveillance system, now, mostly when they see it's almost dead, then they just wheel them to hospitals. And now for hospitals, we're actually capturing the data at that point. So I don't know whether that answers the question about more maternal death captured in facilities, unlike communities.
Thank you very much. Matron Margaret, do you have anything else, any final remark to add, Dr. Moses or Matron Margaret or Dr. Squirrel?
I'll start by saying thank you very much for this opportunity to share our experience in managing such a complex system here in Sierra Leone. I'd like to say also, I saw one of the questions, are we sure that there are more deaths in the hospital than in the community? I think we have succeeded in capturing community, hospital level and health facility level deaths of mothers. And we still have challenges with capturing all the deaths at community level. And at the moment, that is one of the areas of focus and priority for strengthening the MDSR system. You know, it's been a journey getting the system up and running and integrating it into all the quality of care and disease surveillance apparatus that we have. And so far, we've seen that it has provided us with a lot of useful data that we can now use for action. In fact, we've already started using this information for action. We've introduced the ambulance service. We've tried task shifting of cesarean sections for and emergency surgeries for pregnant women to community health officers who we've trained to provide this service. We're working on getting additional medicines to manage PPH. We're also looking at the possibility of introducing anti-shock garments, non-pneumatic anti-shock garments during referrals as well. So these are some of the activities we're hoping to implement in coming years, and we're hoping that we would continue to see an improvement in our maternal mortality, because when you look at the data from 2013. When we were having 1,160 deaths per 100,000 live births in 2013, compared to 2019, when we saw that there has been a reduction of almost 40%. It means that some progress has been made. And we're hoping that as we implement these new strategies, we will continue to make even more progress going forward. Thank you.
Thank you very much, everyone, for attending the webinar, and especially thank you very much, Dr. Moses, Matron Margaret, Manna, Dr. James Square, for really participating for us, and to the whole Ministry of Health and Sanitation of Sierra Leone for really participating and answering to all our questions. It's fascinating really what is happening in all Sierra Leone about the MPDSR process. We will share with you all the slides and recordings. Please visit our website. If you have any questions or comment, reach out to my email below. Don't hesitate. And also we know that all our systems may not be perfect, right? But just to see the commitment of your leadership in really bringing and taking all these processes forward, it's really fascinating and inspiring. So thank you very much, and we will connect soon with all of you again. Thank you. Bye.
Thank you. Thank you. Bye, everyone from Sierra Leone.
This has been interesting.